Hey everyone, Ryan here, and welcome back to our Pediatrics series. This video is going to be all about space management, which implies that we have space to manage. And luckily for us, there is, in the average patient, some natural space that occurs as part of the transition from primary to permanent dentition. And we can utilize this space to our advantage to prevent or at least limit crowding. Because crowding, after all, is just the result of a discrepancy between arch dimension and tooth dimension. So baby teeth provide function for chewing and speaking, but also one of their most important purposes is maintaining space for the permanent dentition. If you pulled out all of your baby teeth early, the permanent first molars would drift mesially, leading to arch length discrepancy, severe crowding, ectopic eruption, among other problems. So early loss of a primary tooth, say if it has caries and it falls out on its own, an abscess and it needs to be extracted, or if there's ectopic eruption of a permanent tooth and we need to clear away for it, all of these are scenarios, and we should have some consideration for us to step in and artificially maintain space in lieu of the primary tooth. So let's talk about some of the natural spaces that occur in the dental arch from the transition from primary to permanent dentition. So first we have our primary or primate space. The primate space refers to about 1.5 millimeters of space that naturally appears mesial to the upper primary canines and distal to the lower primary canines. This space is lost early at around 6 years of age with the eruption of the permanent first molars. So as the permanent first molars, which are not shown here, erupt into the mouth, you can think of them pushing these teeth mesially just a little bit to close that space. Same for the upper. So it makes sense that we're losing this space at 6 years of age because that's when the 6-year molars are coming in. To help you remember this, think of P standing for primary, and this space is lost at the end of the primary dentition. Or you can remember that it's the primary or first space that's observed in the dental arches. Leeway space refers to the difference in mesiodistal width between the primary canine and molars and the permanent canine and premolars, which are smaller than the teeth they are replacing. As you can see here, there's a certain amount of space that's left over if we've lost these primary teeth and replaced them with these permanent teeth. So this exact number of space varies greatly depending on the source you look at. We have in the literature from anywhere from 1.7 to 2.5 millimeters per side in the lower arch, and a little bit less at 0.9 to 1.5 millimeters per side in the upper arch. I tend to just remember the 1.5 and 2.5. This leeway space is lost later at 11 to 12 years of age with exfoliation of the primary second molars, or the E's, I like to call them, and the eruption of the permanent second molars. So of course the permanent first molars are already in, then at about 11 or 12, we're losing this tooth and gaining this second molar, which you can again think of kind of pushing everything in a mesial direction. The leeway space is also sometimes called the E space because the creation of this space depends mostly on the exfoliation of the E's, or the primary second molars. So you can remember L, which stands for late, or leeway space, or E space, has to do with exfoliation of the E's. And the last naturally occurring space I want to talk about are the interdental spaces. This is naturally occurring space between the front permanent teeth during the transition from primary to permanent dentition. And it's mostly due, this is a good boards question, due to the growth and expansion of the dental arches. So some spacing is normal at this stage and should be expected. And in fact, if we don't see any space, we're tending to think that this patient may be due for some crowding later on in life. The quote-unquote ugly duckling stage precedes eruption of the maxillary canines. So we're between about ages 7 and 11. And so this is where you often have these gaps between the front 4 teeth, especially between the front 2 teeth. Again, this is a pretty normal stage in tooth development. So, what can we do about all this space? Well, our treatment all has to do with timing and when we decide to intervene. Space management is proactive. So we manage and hold, usually leeway space, before primary teeth are lost in order to hold on to as much arch perimeter as possible. Space maintenance is one step later. It's reactive. We maintain space after premature loss of a primary tooth because if nothing's done, permanent teeth will push and drift mesially and you would lose arch perimeter, which is usually a bad thing. And the last step here is space regaining, which is retroactive. So this is where we want to regain space, about a maximum of 3 millimeters of space is possible, that was lost from premature loss of a primary tooth and subsequent permanent tooth drift. So we were a little bit late to the game here, and now we have to back up the clock, so to speak. So the earlier you can act, the more space you can conserve, and usually the better off your treatment result will be. So let's talk some specifics. So if the primary incisors are lost, the A's or the B's, what can we do? Well, this is not very common that you lose these teeth prematurely because, well, these are the first teeth to fall out of the mouth anyway. But if they did, they could cause localized space loss. Again, not too big a deal in the case of A's and B's. We can use a kitty partial to replace those missing teeth for now to both hold space and also provide some function in terms of speech and chewing and also aesthetics, so there isn't a big gap between their front teeth. But again, this is kind of to be expected. Primary incisors are lost relatively early on. Aesthetics usually isn't a big deal here, and usually the permanent teeth are ready to erupt underneath. Now, what if the primary canines are lost early? These are the C's. Well, this causes lingual collapse of the incisors and therefore loss of arch length. And just for review, arch length refers to the distance from the contact point between the central incisors to the mesial contact point, which is out of view here, of the permanent first molars. So it's this distance right here. That is our arch length. So if we get lingual collapse of these teeth, we're losing arch length. So the primary canines are relatively important to maintain arch perimeter and length. So what can we do if we notice early loss of a canine? Well, we can use a lower lingual holding arch or a Nance holding arch from the permanent first molars. So the lower lingual holding arch is used for the lower arch and the Nance is used for the upper arch. And I'll show you what a Nance looks like in the next slide, but here is what a lower lingual holding arch looks like. It's banded to the first permanent molars with a strong wire that curls around and passively contacts the lingual surfaces of these teeth to both hold the molars back and hold the incisors forward. What's really important for the lower lingual holding arch is that we need to wait for once the lower permanent incisors erupt, because these commonly erupt lingually, and if we place this appliance before they erupt, we can actually trap the permanent incisors underneath the appliance, which is not a good thing. So we typically want to wait until these 4 teeth are in the mouth. Next, let's move to the primary first molars. What happens if they're lost early? Well, losing D's early is not quite as big a problem as losing a C or an E, but still should absolutely be managed if given the opportunity. So what we can use is what's called a band and loop, which is shown up here. And so a crown or a band is placed around the permanent first molar, or in this case, I should say the primary second molar, or the E, and it has a strong wire attached to either the crown or the band that contacts the next closest tooth to prevent tooth migration into that space. Or we can use a lower lingual holding arch, which we see here, and you can see how the D's were lost prematurely on either side of the arch. Or we can use a Nance appliance, which is shown here. So for the Nance, you have bands around the permanent first molars. Instead of a wire contacting the lingual surfaces of the teeth, you have this acrylic pad or acrylic button that contacts the anterior hard palate. Some people don't think this is as effective because it's not tooth-borne, it's tissue-borne, which there certainly is some truth to that. So you can also make a lingual holding arch that looks similar to the lower lingual holding arch if you prefer to have a tooth-borne space maintainer. And lastly, let's talk about the primary second molars and if they're lost early. Well, we spent a lot of time talking about the leeway space or the E space, so you can imagine that this is going to be a problem because the E's are our keys to the leeway space. And if we lose them early, we miss out on a few millimeters that can mean the difference between non-extraction and extraction orthodontic treatment. So this is a big deal if we can make a difference early on. What we can use is called a distal shoe. And so distal shoe is shown in both of these images radiographically and clinically. You have a band or a crown around the D, so that's the primary first molar, with an extension that goes subgingivally to hold and guide the mesial aspect of this unerupted permanent first molar to prevent it from drifting and migrating mesially. But what if the permanent first molar is already erupted? Well, then we can just use our classic lower lingual holding arch for the lower or Nance for the upper in order to maintain that space. Typically, that's what's going on, and you can get away with that if this permanent first molar is erupted into the mouth. If it's not, that's when we have to consider using something like a distal shoe. You might be asking, well, why don't we just use a band and loop except reverse? So instead of having the band and loop on the E, like in this picture, we would just put it on the D and have it facing the opposite direction. Well, a band and loop would not work because once the primary first molar exfoliates, there's no abutment tooth holding that space maintainer in. So then we have no D and no E, and we'll likely lose a ton of space. The same can be said for the distal shoe, which is typically why we wait for some amount of the 6 or the permanent first molar to erupt and then use a lower lingual holding arch or Nance. All right, so that was some high yield review of primary tooth loss. Let's talk about eruption timing variations. So what happens if we have variations in our typical eruption pattern that we went over in, I believe, our first video in the series? So let's say a lower second molar erupts ahead of a second premolar, which is certainly possible. You would get loss of leeway space for the second premolar, and it may result in its impaction. So we would use a space maintainer, like a lingual holding arch, to hold the molars back. What if the upper canine erupts ahead or alongside the first premolar? Well, that usually causes the canine to be forced labially, called a vampire fang, or at least looks like a vampire fang. So this kind of high canine can always be treated later on in comprehensive orthodontic treatment. Usually not a whole lot we can do in terms of space maintenance for this scenario. What if we have asymmetries between the right and left sides? Well, again, we talked about this, that about 6 months is within normal limits, but if it's longer than that, we can consider extracting the opposite or contralateral primary tooth if there's early exfoliation in order to keep the midlines on. So in other words, in order to keep all the other teeth from leaning towards the early lost tooth. The amount of root development is also an important consideration. So space maintenance is not necessary if there's no bone remaining between the primary and permanent tooth. So basically, this is saying that if the underlying permanent tooth is just a few months away from eruption itself, there's no bone remaining between that tooth that was lost and the tooth underlying it, well, those teeth next door probably aren't going to tip in and invade that space. So we probably don't need any form of space maintenance if that tooth is just a few months behind. Another reason why routine x-rays are just so important, so we can see that kind of information hiding underneath the gums. So eruptive movement begins on crown completion. We touched on this in the last video in a previous video where after the crown finishes calcifying, the root begins to form, and along with this, those clast cells begin to activate and clear an eruption path so that that tooth can begin to erupt. The average tooth pierces bone with 2/3 of root formation. Remember, that's our 2-3 rule. And it pierces gingiva with about 3/4 root formation. The rule of 7 is another great high-yield thing to remember. Premolars are supposed to erupt into the mouth at between 10 and 11 years old, as we can see here. Again, I keep revisiting this because it's just such a great tool. I love that acronym we talked about. And about 2 to 3 years before it erupts into the mouth, we expect our physiologic root resorption of the primary molars. So if our primary molar has to be extracted before age 7, we're going to be left with a lot of bone overlying that premolar. So it's actually going to delay the eruption of the premolar because we have to wait for it to eat through all of that extra bone in order to erupt into the mouth. But if the primary molar is extracted after age 7, the eruption of the premolar can be accelerated. And this is part of the theory behind serial extraction, which we'll discuss in our orthodontics series. So space closure, or as these teeth, we've been talking about mesial drift and migration of the teeth, this kind of space closure is going to occur mostly within the first 6 months after a tooth is lost. So you have to act pretty quickly because those first couple months are where those neighboring teeth are going to want to drift the quickest. This is also true for if a tooth is extracted. And the theory is those first couple, 4 to 8 weeks specifically, you get the most tooth movement because those inflammatory mediators are activated when a tooth is extracted or lost. This is tipping, not bodily movement. We can talk more about that in orthodontics as well. And active eruption of a neighboring tooth tends to increase the amount of space lost. We talked about what's called early mesial shift, where we have eruption of those first molars pushing everything mesially, and late mesial shift when we have those second molars closing that leeway space. So that's part of the theory and connects with this idea of space closure. So lastly, we're going to finish this video by talking about ectopic eruption and ankylosis of primary teeth. So lots of great high-yield facts on the board exam in this video. So let's keep it going. Ectopic eruption of incisors, and I'm mostly talking about the ones here, the permanent central incisors. So we can have lingual eruption of those incisors, like we see here, and it causes this kind of double row of teeth, and this will resolve on its own unless we over-retain the primary incisors, in which case we can just take those guys out and hope for some self-correction and drift of those incisors into that space. We can also have lateral eruption of the ones due to early exfoliation of a primary lateral incisor. Again, think of teeth erupting into the path of least resistance, and if we've lost the primary lateral, those teeth might want to erupt and drift in that direction. So if that happens, we extract the contralateral primary lateral. So let's say this tooth was already gone, this tooth starts to drift this way, our midline is starting to get off, and so we would extract potentially this primary tooth to encourage everything to kind of shift back to normal to avoid a midline deviation. And I should specify ectopic eruption is defined as a permanent tooth that's erupting along the wrong path. So it's out of its normal position. All right, we'll move to ectopic eruption of premolars. So both 4s and 5s we're talking about here. We can have distal eruption of those premolars, most common in the mandibular second premolar, where it resorbs only the distal root of the primary second molar. And so that primary second molar hangs on by dear life by that mesial root, and the second premolar gets knocked off course. Or we can have buccal or lingual eruption, which is very common. And what we would do is extract the primary molar if it's not quite ready to exfoliate within a few weeks, because we want to avoid a situation like this where that premolar may not even be salvageable at this point. And we can have ectopic eruption of molars, specifically those permanent first molars. And mesial eruption of the permanent first molars is extraordinarily common, and it's something that we definitely can intervene with and help out. So these molars, especially the maxillary first molars, like to get impacted underneath the distal aspect of the primary second molar. You can see this tooth right here is getting caught underneath this primary second molar. So if it's minor, and we have about a 1 millimeter of what's called an enamel ledge, you can try inserting an elastic or an elastomeric spacer or separator, or hope for a spontaneous jump of this permanent first molar into the proper space. So 2/3 of these will spontaneously self-correct if the ectopic eruption is minor. However, if it's more major and it's starting to resorb the pulp chamber of this E, then we should consider a unilateral or bilateral appliance, like a Halterman appliance, to distalize this 6 and correct its path. If it's more like a 4 millimeter enamel ledge and this E is extremely mobile, we can consider extracting that E altogether and regain space with a distalizing appliance, again pushing this tooth back into its proper position to maintain that arch length that is just so valuable and the focus of much of this video. And then after it's in the correct position, we would maintain that space with a Nance holding arch, for example. The good news with this kind of situation is that these E's very rarely abscess. They're used to having that physiologic root resorption. So that's good news, but we don't want to lose arch length and we don't want to mess up the development of the arches. So we can intervene if we start to see something like this. And lastly, let's talk about ankylosed primary molars. And we could spend a whole video on ankylosed primary teeth, but let's just cover the highlights briefly for the board exam. So prevalence, 1% African American, 4% Caucasian, more common in the mandible, and E's are more common than D's. So the mandibular primary second molars are the most commonly ankylosed primary tooth. So the best way to tell if a tooth is ankylosed is if it's submerged below the plane of occlusion, also called infraoccluded. And you can appreciate how these teeth, all of these primary molars in fact, are below the plane of occlusion, which is up here. And that's because they're not erupting. Now, there are also other mechanisms of failure of eruption, so I don't want to equate that with ankylosis, but it's very possible that these teeth are histologically fused to the underlying bone and they're not erupting properly. So they're also not going to be mobile if they're ankylosed. So the research says you get a hollow sound when it's tapped. It's this high-pitched sound on percussion, but I'll tell you, this is extremely hard to hear. But the board exam likes you to know that a hollow sound is diagnostic, but I'm just telling you, as your friend, this is very hard to use as a diagnostic tool. And lastly, you have radiographic loss of PDL space, which is also very challenging to diagnose. So what can we do about an ankylosed primary molar? Well, usually there's no treatment required, and the general recommendation is to await normal exfoliation of the infraoccluded primary teeth. But if adjacent teeth are drifting and tipping, resulting in space loss and loss of arch length, well, then we can extract those primary teeth and put in a space maintainer to maintain and hold that space, which is that should be the motto for this video: hold that space, because that is what we're trying to do with space management. All right, so that's it for this video, guys. Thank you so much for watching. I hope you enjoyed and learned a lot about space management. Please like this video if you enjoyed it and subscribe to this channel for much more on dentistry. If you're interested in supporting this channel and what I do, please check out my Patreon page. A huge thank you to Michael Raja, Reb Boyd, Leonilla Bunger, Zahir Anani, David Jaden, Isabella Caldas, Ali Benjgir, Badir Hefnawi, and all of my patrons for their support. You can unlock extras like access to my video slides to take notes on and practice questions for the board exams. So go check that out. The link is in the description below. Thanks again for watching, everyone, and I'll see you in the next video.